So today we have an interesting case involving a 45-year-old lady who has been experiencing chronic, non-specific episodes of severe abdominal pain along with nausea and vomiting. Interestingly, her plain radiographs, ultrasound, barium studies, and even endoscopy have all been reported as normal. It's definitely one of those cases where we know something more is going on, so we turn to cross-sectional imaging, specifically a CT scan of the abdomen and pelvis with both intravenous and oral contrast. Now, diving into the imaging findings, there's a smooth lesion of about 4 centimeters in diameter with fat attenuation in the small bowel. It's showing a characteristic targetoid appearance on the sagittal image. This particular appearance is quite classic and suggests that we are dealing with an intussusception, specifically involving the small bowel. And importantly, there's no evidence of large or small bowel dilatation, no free gas, and no free fluid seen, which are key factors in ruling out complications like perforation or significant ischemia at this point. So based on these findings, the diagnosis we are leaning toward is intussusception of the small bowel, most likely due to a benign lesion such as a lipoma. Liposarcoma, a more sinister possibility, is considered extremely unlikely here, but of course it cannot be entirely ruled out without histological confirmation. Now, talking about intussusception, it's interesting because it's quite rare in adults. It's much more common in the pediatric population, but in adults it accounts for around 5% of all intussusception cases. What's even more fascinating is that only about 1% of all bowel obstruction cases are due to intussusception in adults, and it makes up a very small fraction of all hospital admissions related to abdominal complaints. So, what happens in intussusception? Essentially, the proximal segment of the bowel, which we call the intussusceptum, invaginates into the adjacent distal bowel, or intussuscipiens. This telescoping effect can happen anywhere along the bowel. In this case, we are seeing it in the small bowel, but it can also occur between larger segments, like the colon, or the junction between the large and small bowel. In adults, this condition often presents with a range of symptoms, including intermittent or chronic abdominal pain, nausea, vomiting, and sometimes fever or diarrhea. It can be quite easy to misdiagnose at first, since the symptoms can overlap with other more common gastrointestinal issues. Now, it's important to note that in adults, intussusception is most often secondary to a pathological lead point, typically a tumor. While in children, enlarged lymph nodes or hyperplastic lymphoid tissue can be the cause, in adults we're always more concerned about malignancy. Around 20 to 50% of intussusception cases in adults are associated with malignant causes, so that's something we always keep in mind when evaluating these patients. Speaking of benign causes, small bowel lipomas are the second most common benign tumors of the small bowel, right after leiomyomas. These lipomas are usually submucosal, and they can project into the bowel lumen, potentially causing intussusception, as we suspect in this case. Most small bowel lipomas are unifocal, though they can occasionally be multiple, which is something to keep an eye out for in these scenarios. When it comes to diagnosing intussusception, ultrasound is particularly helpful, especially in the pediatric population. You might hear terms like pseudokidney or target sign when discussing ultrasound findings in intussusception. Essentially, the pseudokidney appearance is created by the intussusceptum being the center and the intussuscipiens forming the outer ring, creating that classic target-like image. However, ultrasound can have its limitations in adult patients, especially if there's a lot of bowel gas or if the patient has acute intestinal obstruction. That's where CT really shines. In adults, CT is the preferred modality, as it helps us not only confirm the diagnosis, but also evaluate for any complications like bowel ischemia or perforation, and in this case to ensure there's no evidence of malignancy driving the intussusception. In this case, it also helped us visualize the fat within the lesion, pointing toward a lipoma as the likely cause. So the management for this lady would definitely involve a surgical consultation. The intussusception could compromise the blood supply, leading to ischemic or necrotic bowel if left untreated. In benign cases like lipomas, surgical resection is typically performed to prevent recurrence and resolve the obstruction. And finally, just to round things off, small bowel intussusception can often be challenging to diagnose early because the symptoms can mimic so many other conditions. But thanks to modern imaging modalities like CT, we can often catch these cases early enough to intervene before complications develop. Surgical intervention, while necessary, tends to have a good prognosis, especially when the cause is benign, like a lipoma. Thank you so much for joining me today in breaking down this case. If you found this discussion helpful and want to explore more fascinating radiology cases, make sure to subscribe to Radiology Made Easy. And if you'd like to support us in continuing to provide you with these insightful cases, please check out the Buy Me a Coffee link in the description below. Your contributions really help us keep this content flowing. Thanks again for tuning in, and I look forward to seeing you next time.